Hello friends, today we are going to discuss the question which was asked in DRNV Critical Care exam June 2022 and it was related with the ventilator associated pneumonia. And the question was definition of the ventilator associated event and ventilator associated pneumonia and the prevention strategies for the VAP. So as we all know, there are three nested types of ventilator associated event in the adult. The first is ventilator associated condition. Second one is infection related ventilator associated complication. And third one is possible VAC. So we'll see what is this. So ventilator associated event and the ventilator associated condition are synonymous and it is defined as increase in daily minimum positive peak expiratory pressure of more than or equal to 3 sustained for more than or equal to 2 calendar days after more than or equal to 2 days of stable or decreasing daily minimum peak, or increase in the fraction of inspired oxygen, that is FiO2 of more than 20 points, sustained for more than or equal to 2 days after more than or equal to 2 days of stable or decreasing daily minimum FiO2 levels. So what is infection related ventilator associated condition? So along with this ventilator associated event or ventilator associated condition, which I have described earlier, if there is a sign of infection means if there is any abnormal temperature of more than 38 degrees Celsius, or if the blood pressure WBC counts are less than 4,000 or more than 12,000, or if one or more new antibiotics started that continue for more than or equal to 4 days, and all this beginning within 2 days before or 2 days after ventilator associated condition, then it is known as infection related ventilator associated condition. Now what is VAD? So along with the combination of these infection related events, plus there is if we have some culture positive for the positive in we have some tracheal culture which showed the growth of the bacteria, then we can say the possible it is a possible ventilator associated pneumonia. So let's have a look on the SHIA guidelines on the prevention strategies for the ventilator associated pneumonia. So essential practices include avoid intubation if possible, use NIV pressure ventilation for selected population. So what I want to say is if you can manage the patient on NIV or high flow nasal cannula, then manage it and avoid the intubation whenever there is no need to intubate the patient. And even if you will intubate the patient, then we need to assess daily for extubation trial without control to that patient who are not having any contraindication to the weaning. Then the next preventive strategies take step to minimize unplanned extubation and reintubation. So what I want to say is follow the proper protocols for extubation so that we can avoid the reintubation and possibility of the infection. Then the next strategy is to avoid fluid overload. Then provide regular oral care with toothbrushing or gauze if noted. So and elevate the head of the bed unless medically contraindicated. So you can change the ventilator circuit, but not frequently. You have to change only if it is visibly soiled or if there is any malfunction. Then prevent the condensate from reaching the patient. Make use of cuff endotracheal tube. Maintain the cuff pressure and volume at minimal occlusive setting. Suction oral secretion before each position change. Then additional approaches are the interrupt sedation daily. Then utilize endotracheal tube with the subglottic secretion drainage port for older pediatric patients expected to require more than 48 to 72 hours of mechanical ventilation. And then consider early tracheostomy to avoid the infection. Or the recommendation which are generally not recommended are prolonged systemic antimicrobial therapy for ventilator-associated tracheitis, and the selective oropharyngeal or digestive decontamination. Very low evidence, so and it is generally not recommended. Prophylactic probiotics. So what they're saying is this prophylactic probiotic is increasing the risk of systemic bacterial and the fungal infection. So there is no evidence of using prophylactic probiotic in case of in case of prevention of ventilator associated pneumonia. And regarding selective oropharyngeal and digestive decontamination, what they have suggested is we can use only in the ICU where there is a high resistant bacterial load. Otherwise, there is no evidence of of practicing selective oropharyngeal and digestive decontamination. Then they said avoid the oral care with the antiseptic like chlorhexidine. So definitely we need to provide the oral care with toothbrushing, but the use of the chlorhexidine. So according to the trials, the chlorhexidine doesn't have any role in the prevention of the VAC, but the few studies showed that if we use the chlorhexidine, then the chances of the mortality is the high. So then stress ulcer prophylaxis. So they said that the use of the PPI is associated with the ventilator associated pneumonia, but there is no trials in supporting or favoring this statement. Then use of silver coated endotracheal tube. Again, there is no evidence of using silver coated endotracheal tube in the context of prevention of the ventilator associated pneumonia. And also there is no recommendation for the closed or inline suction. Thank you.